Hi guys, welcome to our gross anatomy lecture. Today we are going to talk about the osteology. Mainly we are going to talk about the humerus. So the humerus, it's a long bone, one of the longest bone in the upper limb, the longest bone in the body being the femur. So the humerus, it has a proximal end, right? You can actually see this, the proximal end, and it has a distal end. So this is your humerus. This is a proximal end and this is a distal end. So proximally, the humerus, it actually articulates with the scapula via the glenohumeral joint, right, which is between the head of the humerus, which is about 1/3 of a sphere, and a glenoid cavity, right? So you're going to have a glenohumeral joint being formed proximally. Then distally, it actually articulates with the radius and the ulna, right? So it articulates forming what we call an elbow joint, is it? So let's take a look at the proximal aspect of the humerus. Right here, your humerus is going to have a head. This is the head of the humerus, which we said is 1/3 of a sphere that articulates with the glenoid cavity via the glenohumeral joint. The head of the humerus, it actually gonna be lined with hyaline cartilage, right? And then from the head, we're going to have what you call an anatomical neck. This anatomical neck is very important because when we are going to talk about the glenohumeral joint, it is where the capsule of the joint attach laterally. Below the anatomical neck, we are going to have tuberosities. We're going to have a posterior greater tuberosity and um, an anterior lesser tuberosity. Right. So you're going to have a certain muscles attaching to the greater tuberosity, which are going to be part of your rotator cuff muscles. That is going to be here. You're going to have the attachment of your supraspinatus muscle here, your infraspinatus, and your teres minor muscle. And then the lesser tuberosity is going to have the attachment of your subscapularis muscle. Between the greater and the lesser tuberosity, there's going to be a groove, which is called an intertubercular groove or a bicipital groove. In this groove, you're going to have the long head of your bicep muscle. If you remember, the bicep actually has two heads. The long head is going to be within the intertubercular sulcus or the bicipital groove, as it's going to attach the supraglenoid tubercle. Good. Right. This groove is actually going to have some lips. You're going to have this lip, which you call the lateral lip, and then you're going to have the medial lip, and then you're going to have your floor. So using the mnemonic, the lady sitting between two majors, you're going to have specific muscles that attaches to the lateral lip. That is going to be your pectoralis major muscle. That's the incision of the pectoralis major muscle. And then the floor, the lady sitting between. So the floor, you're going to have the latissimus dorsi, and then the medial lip, you're going to have your attachment of your teres major muscle, right? So between the head of the proximal head of the humerus and the shaft, you're going to have a surgical neck, which is just a constriction. And take note, NB, the surgical neck is the portion of the humerus that is common to fracture. This another orientation for the surgical neck, right, is the most common fractured position of the humerus. Right, let's take a look at the shaft of the humerus. Let us take a look at the shaft of the humerus. Right, so this is the shaft of the humerus. At the mid of the shaft, laterally, you're going to have the tubercle of the insertion of the deltoid muscle, right? And then posteriorly below the tubercle, you're actually going to have a groove that is called the spiral groove, right? Or a radial groove. In this groove, you're going to have the radial nerve, and the profunda brachial artery. Right. The shaft of the humerus, it's actually going to have the insertion of the coracobrachialis muscle just medial to the tubercle of the deltoid on the lateral aspect of your humerus. So you're going to have the origin, the insertion of your coracobrachialis muscle. All right. And also in the midshaft, you're also going to have the origin of your brachialis muscle, as you're going to see in the next picture. Distally, or the distal end of the humerus, you're going to have, like we said, it articulate with the radius laterally and the ulna medially. So you're going to have two prominences, one medial and the other lateral. Medially, you're going to have what's called the medial epicondyl, which is actually larger than the lateral epicondyl. The medial epicondyl is an important anatomical point because it facilitates the insertion of all your flexor muscles of the forearm, right? Of most of your flexor muscles of the forearm. And then the lateral epicondyle is actually important for the insertion of your extensor muscles of the forearm. Right. Just above the medial epicondyle, you're going to have this ridge, which is called the medial supracondylar ridge, as well as laterally, you're also going to have your lateral supracondylar ridge. Right, so from this diagram, this is your proximal end, which is the head of the humerus, 1/3 of the sphere, the anatomical neck, the greater tuberosity, the intertubercular groove or the bicipital groove, which accommodated by the bicep, the long head of the bicep tendon, the lesser tuberosity, the attachment of the subscapularis muscle. This on the distal end of the humerus. So you can actually see those bony prominences. Medially, you're going to have the medial epicondyle, which is larger than the lateral epicondyle, which we said the medial epicondyle is going to be the attachment of your flexor muscles of the forearm. Lateral epicondyle, your extensor muscles of the forearm. Right. You're going to have what you call the capitulum and the trochlear. The capitulum is going to receive the head of the humerus, or is going to articulate with the humerus. The trochlear is going to articulate with the ulna, right? So behind the trochlear, posterior to the trochlear, you're going to have what we call an olecranon fossa, right? For the articulation, or it accommodates the olecranon process of the ulna during extension. Good. Right. Let's take a look at another view. Right. So this is your capitulum articulating with the head of the humerus. This is your trochlea articulating with the ulna. Above the trochlea, you're going to have a depression or a fossa called the coronoid fossa. So during flexion, you're going to have this coronoid process being accommodated into the coronoid fossa. And then during flexion, you're going to have this head of the humerus being accommodated into the radial fossa. Right. So basically, that's the gross anatomy of your humerus. Let's take a look at some clinical correlates. So your humerus can be fractured. So it can be fractured mainly on the sagittal, on the sagittal neck, right? That's where it receives most of its fractures, right? So when the humerus is fractured at the sagittal neck, it is actually going to cause axillary nerve palsy, which means you're going to damage the axillary nerve, because the axillary nerve has close relations with the sagittal neck. Good. And then you can also have greater tuberosity fracture as well as anatomical neck fracture. Usually the greater tuberosity fracture is due to forced abduction, right? So you're going to have or a forced contraction of your supraspinatus muscle, which will actually cause your greater tuberosity fracture. You understand? In the shaft of the humerus, you can actually fracture the humerus at the level of the radial groove. At this level, right? So at this level, you're actually going to damage the radial nerve because the radial nerve is in close communication with the radial groove. Distally, you can actually have subcondylar fractures, and here you can actually damage the ulnar nerve that will be posterior to the medial epicondyle, the radial nerve, and the median nerve. Right. Let's take a look at some fractures at the level of the attachment of the deltoid muscle. So we said the deltoid muscle, it actually attaches. Okay, let's take a look at another diagram. Right, so listen here closely. This is the attachment of the deltoid, which is the deltoid tuberosity. If a fracture is going to occur above the deltoid attachment, what is going to happen? So if a fracture happens at this level, you're going to have a distal fracture and a proximal fracture limb. So what happens is this. If it happens above the deltoid tuberosity, you're going to have the muscles, the pectoralis major, latissimus dorsi, teres major, they will actually adduct the proximal limb, right? While it's the deltoid tuberosity, together with the bicep and the tricep, they'll actually proximally move the distal fragment. So the distal fragment will move upward, while the proximal fragment will be adducted. But if a fracture is going to occur below the deltoid attachment, like here, the proximal fragment is going to be abducted, right, due to the deltoid muscle. And then the distal fragment is going to be proximally displaced due to the muscles of the bicep and the tricep. So those are the fractures. If there is a surgical neck fracture, we damage the axillary nerve. Mid-shaft fracture, the radial nerve. Supracondylar ridge fracture, the median nerve, outer nerve, radial nerve damage. So thank you so much. See you next time. Take care.